Hello, good afternoon. The topic our group will be discussing is all about diverticulitis. But first, let me introduce to you all the presenters. First, we have here Irish J.R. de los Santos, yours truly. Next, Andrea L. Hakang, Honey Girl F. Ravina, Natasha Cassandra Tabios, Hannah Micaela B. Viloria, Angelica Lay P. Vite, and Shania Yangat. Our presentation will be guided by these parts. So we have here the definition, the etiology, the pathophysiology, diagnostic examinations, the signs and symptoms, nursing management, medical and surgical management, and also the nursing care plan. So let's go on to the definition of diverticulitis.
So, diverticulitis is the infection or inflammation of pouches that can form in the intestines. These pouches that form are called diverticula. They are generally not harmful and can show up anywhere in the intestines. When there are diverticula in the intestines, it is called diverticulosis, not to be confused with diverticulitis, which is the infection or inflammation of the diverticulas. Sometimes diverticulitis is minor, but it can be severe with a massive infection or perforation of the bowel. There are two forms of diverticulitis, namely acute and chronic. In acute, a person may have one or more severe attacks of inflammation and infection, while chronic is the inflammation and infection that may go down but never clear up completely. So, these two pictures that are shown are two pictures that shows the difference between a person without diverticulitis and a person with diverticulitis. In the first picture, there are no holes, and in the second picture, the holes are the diverticulas. So, this presents the difference of diverticulosis and diverticulitis. In diverticulosis, there is only a presence of diverticula in the intestines, while in diverticulitis, there are inflammations and complications of the diverticula and possibly bleeding. Now, let us move on to etiology.
So we have learned a while back that diverticular disease develops when pouches form along your digestive tract, typically in your colon or large intestine. These pouches, or what we call the diverticula, can become inflamed or infected, which may occur when feces or partially digested food blocks the opening of the diverticula. Although there's no single known cause of diverticular disease, several factors can increase the risk of developing diverticulitis. This includes genetics, diet, decreased immune function, having obesity, smoking, changes in the gut microbiome, and certain medications such as steroids. So let us now move on to the pathophysiology of diverticulitis.
For the pathophysiology, it is discussed earlier that the etiology is unknown, but several factors can trigger diverticulosis leading to diverticulitis. So we have here high fat, low fiber diet. The people or those older adults with the age of 40 and above, low physical activity levels, and genetics. From this, the colonic wall elasticity decreases and increases risk of mucosal herniation. When we say herniation, it means the occurrence when tissue such as part of the intestine protrudes through a weak spot in the abdominal muscles. So, as partially digested food, water, and digestive enzymes enter the large intestine in the form of chyme, colonic movement is triggered in the form of segmentation. So segmentation contractions occur as a result of the circular muscle layer, which results in slow mixing. This contrasts with peristalsis of the intestinal longitudinal muscles, which cause forward progression of the luminal contents. So peristalsis is the series of wave-like muscle contractions that move food throughout the digestive tract. It has been thought that the waves of high intestinal pressure during segmentation lead to muscular atrophy and herniation of the colon wall, or the mucosa and submucosa bubbles out through the weak spot, in turn form diverticula. So, as the pressure increases in the weak spot, blood vessels can rupture, causing for GI bleeding. If there is bleeding, there is an opening. So bacteria can enter and undigested food stuck in the protrusions, causing the diverticulum or diverticula to be infected. This is known as diverticulitis. The clinical manifestations will be presented and discussed further in the next slide. So if diverticulitis will be left untreated or there is a delay on the detection, complications may arise like abscess, which is the collection of pus from the infection and may form around the infected diverticula. If this go through the intestinal wall, you could get peritonitis. This infection can be fatal. You'll need treatment right away. Next, perforation or tearing in the intestinal wall. This can lead to abscess and infection because of waste leaking into the abdominal cavity. Next, scarring. Scarring can lead to stricture or blockage of the intestine. And then we have fistula or fistulas. This can develop if an infected diverticulum reaches a nearby organ and forms a connection. This most often happens between the large intestine and the bladder. This can also lead to a kidney infection. Also, fistulas can form between the large intestine and either the skin or the vagina. And lastly, we have stricture, which happens when the colon narrows in the affected area. Next, for the diagnostic examinations, first, we have the physical examination. Diverticulitis can present with a range of physical findings mirroring the severity of the inflammation and the presence of complications, including the localized abdominal tenderness, the abdominal distension, the tympanic abdomen to percussion, a tender mass that signifies abscess formation, the hypo or hyperactive bowel sounds, the absence of bowel sounds that indicates perforation, generalized abdominal pain with rebound and guarding also signifies perforation, and the urinary tract findings that includes suprapubic, flank, costovertebral tenderness, pneumothuria or the air in urine, the fecaluria or the stool in urine, or the purulent vaginal discharge. So for elderly and immunocompromised patients that who take corticosteroids may have unremarkable findings on physical examinations, even in the presence of severe diverticulitis. So these patients must be evaluated with a high index of suspicion to avoid a delay in establishing the correct diagnosis. So if a fistula forms, physical examination findings may vary depending on the type of fistula. So colovesicular fistulas may present with urinary tract symptoms such as suprapubic, flank, or costovertebral angle tenderness. Fecaluria or pneumothuria can also be observed. Female patients with colovaginal fistulas may present with a purulent vaginal discharge. So women needs pelvic examination. I'm sorry. Also, we have blood, urine, and stool test. This test is used to look for infection. CT scans look for inflamed or infected diverticula, and the liver enzyme test. This is to rule out the liver problems. Next, let's proceed to the signs and symptoms of diverticulitis.
The most common signs and symptoms of like pain in the lower abdomen persistent for days without letting up. However, people of Asian descent may be more likely to feel diverticulitis pain on the lower right side of their abdomen. Other symptoms of diverticulitis can include nausea and vomiting, lack of appetite, fever, bloating or gas, constipation, or less commonly diarrhea. And the next we'll be discussing nursing management.
So for nursing management, perioperative administrations should be administered to all patients, which includes administer nothing by mouth, administer IV fluids, institute nasogastric tubing if indicated, keep client on bed rest. Stop taking any certain medications, vitamins, or supplements around 7 days prior to surgery. If you have diabetes and take insulin or another oral or injectable medication, ask your healthcare provider if you need to temporarily stop it or alter the dose before surgery. Next is increase patient comfort and rest. So promote bed rest and encourage daily exercise such as walking, which increase bowel peristalsis. Next is to get relief and or diminish discomfort for your patient. Administer pain medications, antibiotics, and anticholinergics. High fiber diet. So healthcare may prescribe liquid diet for a short period of time. Healthcare providers may prescribe high fiber products to enrich a patient's diet. These fiber supplements should always be swallowed with 8 ounces of water. Handle patients' anxiety with psychological support. Encourage fluid intake to discourage constipation and an inflamed bowel. Instruct your patient about the disease and the benefits of the high fiber diet and proper nutrition. Be proactive in all treatment procedure, including follow-up. Evaluate patient progress and look for evidence of no abnormalities. Record and report signs and symptoms. For medical treatment, it depends on severity of signs and symptoms. For acute or uncomplicated diverticulitis, antibiotics to treat infection, although new guidelines state that in very mild cases, they may not be needed. A liquid diet for a few days while your bowel heals. Once your symptoms improve, you can gradually add solid food to your diet. For complicated diverticulitis, if you have a severe attack or have other health problems, you'll likely need to be hospitalized. Treatment generally involves intravenous antibiotics and insertion of tube to drain an abdominal abscess if one has formed. So for the surgical treatment, surgery isn't actually necessary and is the last choice for patients with diverticulitis. Diverticulitis surgery is usually done if you have diverticulitis that is severe or life-threatening. So your doctor may recommend surgery if you have multiple severe episodes of diverticulitis uncontrolled by medication and lifestyle, bleeding from your rectum, intense pain in your abdomen for a few days or more, constipation, diarrhea, or vomiting that lasts longer than a few days, blockage in your colon, keeping you from passing waste or bowel obstruction, a hole in your colon or perforation, and signs and symptoms of sepsis. So the two types of diverticulitis surgery includes the bowel resection with colostomy. So in this procedure, your surgeon performs a colectomy and connects your bowel through an opening in your abdomen. This opening is called a stoma. Your surgeon may do a colostomy if there's too much colon inflammation, depending upon how well you recover over the next few months. The colostomy may be either temporary or permanent. Next is the bowel resection with primary anastomosis. So in this procedure, the surgeon removes any infected colon, known as a colectomy, and sews together the cut ends of the two healthy pieces from either side of the previously infected area, or the anastomosis. So each procedure can be done as open surgery or laparoscopically. Next is the nursing care plan.
So we formulated three nursing care plan. The first nursing diagnosis is acute pain related to presence and inflammation of diverticula as evidenced by pain score of 8 out of 10, verbalization on of left lower quadrant, abdominal pain and cramping, guarding sign on the abdomen, abdominal rigidity and restlessness. So for the independent nursing interventions, first is to investigate pain reports noting location, duration, intensity, and characteristics. Changes in location are not uncommon but may reflect developing complications. Monitor vital signs. Alterations from normal may be signs of infection. Next is to elevate the head of the bed and position the patient in semi-fowlers. This is to increase the oxygen level by allowing optimal lung expansion. Place the patient in complete bed rest during severe episodes of pain to reduce gastrointestinal stimulation, thereby decreasing GI activity. Next is to perform non-pharmacological pain relief methods, relaxation techniques such as deep breathing exercises, guided imagery, and provision of distractions such as TV or radio. This is to provide optimal comfort to the patient. For the dependent nursing interventions, administer analgesics as ordered. Example given, meperidine. This is to relieve pain of diverticulitis. Next, another is to administer antispasmodic agents as ordered. Example, atropine. This is to decrease intestinal spasm.
For the second nursing diagnosis, we have constipation related to inflammatory process of diverticulitis as evidenced by type 1 to 2 on Bristol stool chart, inability to open bowel in the last 3 days. For the independent nursing intervention, keep client on bed rest to promote resting the bowel and promotion of healing, and measure intake and output, weigh the patient daily. This provides information about fluid intake, hydration, dietary needs, and effectiveness of therapy. And commence a Bristol stool chart to monitor the patient's bowel pattern. Encourage to increase oral fluid intake as tolerated, ideally at least 2 liters per day, to help soften the stool and make it easier to pass. Encourage physical mobility and exercise as tolerated to increase bowel peristaltic movement. Dependent intervention, keep NPO status as indicated and ordered. This promotes resting the bowel and promotion of healing. Administer laxatives as ordered, example, Dulcolax and Senocot, to help stimulate bowel movements or loosen up stool to ease its passage. For the collaborative intervention, you will have to encourage fiber intake of at least 25 grams per day for women and 38 grams per day for men as recommended by the dietitian. This is to help the food move through the intestines.
So our third diagnosis is imbalanced nutrition less than body requirement related to lack of appetite as evidenced by weight loss. So the independent nursing interventions include assessing weight, measuring and calculating body fat and muscle mass to establish baseline parameters. Second is to ask the patient's preferences regarding food and drink and discuss with the patient the short-term and long-term nutritional goals, which is to effectively monitor the patient's daily nutritional intake and progress in nutritional goals. Third is to calculate calorie intake, which is the low-fat, high-fiber diet, which is ideal for patients with diverticulitis. Fourth is to help patient to select appropriate dietary choices to follow a low-fat, high-fiber diet, which is used to help soften the stool and make it easier to pass. Then promote adequate and timely fluid intake, which is limited to fluid 1 hour prior to meal, which is used to reduce possibility of early satiety. And lastly, we weigh the patient regularly to monitor effectiveness of efforts and dietary plans. We have the dependent nursing interventions, which is to administer TPN as indicated to promote nutrient utilization and positive nitrogen. Now we have the collaborative, which is to encourage fiber intake to help the food move through the intestines. So that is all for our topic, which is diverticulitis. We hope you learned something. Thank you.